game-changing discussions on the big ideas that shape our thinking. This is One to One.
Hello, welcome to One to One. My guest today is Dr. Zainab Shinkafi-Bagudu, former First Lady of Kebbi State, a consultant pediatrician and global health advocate whose life's work stands at the intersection of community health, public policy, and global governance. She's the founder of Medicaid Cancer Foundation and President-Elect of the Union for International Cancer Control, the first African elected to lead the world's most influential body in global cancer governance. Dr. Zainab, welcome to One to One.
Thank you. It's an honor to be here. Thanks for having me.
Thank you very much for joining us. So you founded the Medicaid Cancer Foundation.
Yep.
Therefore, and you did that at a time when public awareness of cancer was extremely limited, wasn't it? So I'm going to ask you what gap in understanding, in treatment, in diagnosis you felt you were determined to fill. Talk to me about the work of the foundation.
Okay, so I definitely didn't appreciate the scope of the work ahead when we started. It's a 20-year-old foundation now. And when we started, we didn't plan to go into the whole spectrum. It was just coffee evenings, tea with women gathered around to talk to them, check your breasts and if you're bleeding and things like that.
That's where to start.
That's where we started. And it's just the problems came and we have to sit back and respond to them. So that is how we've been able to determine our work plan, if you like, by responding to the needs of the people around us. And the major issue that I still find today, we've come from education and awareness to treatment, fundraising, palliative care, high-level advocacy, trying to influence government policies successfully sometimes and not successfully at other times, implementing National Cancer Control Plan, creating a state cancer control plan in Kebbi and so on. But the big issue that I still find and I will not stop talking about is awareness. That awareness and education, you're right, the needle has moved a little bit, but it's not where it should be. And because we do not have national, triggers that will let people know, men and women, what you need to do at a certain age, not just about cancer, but hypertension, glaucoma. There's so many issues, but we don't screen routinely. We have the plans, but the implementation is not there. And when they're implemented, it can be fragmental and the community is not as prioritized as advocates like myself would like to see it. If we don't educate, and we saw a lot of that in Kebbi, COVID was a real eye-opener. Yeah. We don't educate our people and we just expect them to subject themselves and line up like the lines that we saw in the high-income countries. There was nobody. The vaccines were just sitting there. We had to actively create the demand and generate that demand for different interventions. So awareness is a very big problem in low middle income countries where education is low. How to deliver. We are delivering an HPV vaccine in a country where we have 7 million girls out of school. And we hope to reach, 95%, 90% coverage by 2030. But it's not going to happen if we don't address the methods, how we should be delivering these vaccines.
Yeah. No, absolutely. And it's interesting you talk about HPV vaccination in girls. I mean, and that problem, you're talking about girls, both boys and girls should be vaccinated.
Yes.
Actually, we haven't even looked at that.
Which is wrong. You're going to get me going now. Please. We've sexualized the HPV vaccine, made it a girl's thing, and so the misinformation that comes out and hinders the delivery of that vaccine is sexualized.
Yes.
The naysayers believe that we're targeting girls. If we start by targeting both boys and girls, which a lot of countries have discovered that works better, even within the African context. In Cameroon, they started with just girls, but when they made it by gender, it was more acceptable. And then you can take away some of that misinformation that is around it. Not all, but some, at least But for Nigeria, it was always a cost issue. I was very involved in the advocacy to introduce the HPV vaccine to Nigeria at various levels, nationally and internationally. And we finally saw it being launched about 2 years ago. Nigeria's done very well. If you look at the raw numbers, we have about 15.6 million girls vaccinated today, which if you put in context on the entire African continent prior to Nigeria's introduction, there were just about 6 million people being boys and girls vaccinated. So in 2 years, we've been able to double over that number. But the point is, if we were to really vaccinate every eligible girl, even take away the boy, we wouldn't be able to conduct it in the systems that exist. The school systems, like I mentioned, we have a high out of school population. So that will affect it. But we did well because we're used to delivering outreaches. Now to routinize it and make it something that people go and get in the primary healthcare centers is proving to be more of a task. We do very well with outreaches. We're always doing an outreach for one vaccine or the other. And because we have the numbers, we end up with very high numbers. But the coverage is not where it should be.
Yeah, absolutely. And of course, I'm glad you mentioned the school system. That's a very important vehicle. Nigeria, of course, has the highest number of out-of-school kids.
We have the highest number of everything because we're 230 million people.
So we're going to have some problems with that, but magnified by the population. And doubly important because we're talking about HPV vaccination. And that vaccine is 99% effective, isn't it?
Yes. The studies are coming out more and more, and the effectiveness is being proven. And it's good that we have now long-term studies to help us convince people that are not so sure about the efficacy.
Absolutely. So let's stay, therefore, at the community level. You've done a fantastic job actually in outlining the issues that are prevalent at that level, not least understanding. We can't take for granted the fact that because you line up your fancy screening programs that people will attend. There's a work of advocacy and understanding that needs to be done. Having said that, let's examine the burden of the problem. 70 to 80% of all cancer presentations in Nigeria are late. Absolutely. So at the community level, I'd like to ask, what have you learned about why so many patients in Nigeria still present late?
Well, it's awareness. We take for granted the plethora of information that people in high-income countries have. You go around, there are flyers, there are billboards. Even if we do that, how many people can read them? What languages are we translating them to? We have 130 different languages in Nigeria. How do we reach those people at the community? And like I said, the funds are not allocated to that end of the spectrum. Funding can be budgeted and allocated and even released for procurement of vaccines. When someone will remember, let's go to the school, let's go to the primary health centers and talk to not the girls or their parents, the teachers, the healthcare workers, the community healthcare extension workers. They are not as educated as they should be before we bring interventions. In Kebbi, we had a program that was supported by the World Health Organization and a few other bodies for cervical cancer elimination. And this was mainly screening. And we had to take samples across 10 local government areas of women. There was a certain number we had to get to based on the funds that we had received from both WHO and the state government. And at a point, it started moving slowly. I'd had this WhatsApp group we had created, and slowly, each one of them would come to me and say, really, they understand what I'm trying to do, but they're not being remunerated for it. The work plan for HPV, for maternal health, for any intervention usually doesn't include any extra remuneration for the healthcare workers, particularly at the community level. We assume that it's their work and they're going to do it, but these are people that are so overloaded and overworked, and we really should be doing more remuneration at that level. So that's one lesson that I learned, that we have to put aside funding for healthcare workers. We're losing them at the lower level, at the higher level to different, even internally. Some nurses just give up and they start selling something, wrappers, because they can't cope with the workload and the income that they're taking home. Yesterday, someone sent me one of these clips about a patient, a cancer patient, who was complaining bitterly about the doctor's strike and the effects it has on her treatment, and calling on governments to pay doctors more. I had an exchange with her because I agree that doctors should be paid more, but how are they going to be paid more? If we cannot charge as we're supposed to charge for the tests that we're delivering, government doesn't charge. They charge even less for public sector. And it's definitely not at par. To get a CT scan in the UK will cost you £1,000. If you do the maths, we're doing it here at 100,000 naira in the cheapest of places. So how are we going to pay our bills, pay for the utility, the electricity, and so on, and then pay the healthcare workers adequately as they should be paid? It's subsidy from government, but it's just not there. It's not enough. So there are a lot of issues. If your question was about the community level, the funding issue starts from there. The awareness extends from the patients, the members of the community, to the community gatekeepers, the leaders of that community. I'm talking about our religious leaders, our, traditional rulers, and then those who are representing them. What are the politicians, what do they know? What are they going to advocate for? A little bit now we're seeing some workshops that includes them, but I've been very vocal about this, the need to include the legislative arm of government more in our advocacy and let them actually know. And when we do it properly, it works. When we have a few champions in the law, amongst the lawmakers, we get laws passed that are going to help us.
Sure. So you've been quoted as saying that women carry a disproportionate burden of cancer-related inequity. I'd like to know, what precisely do you mean by that? I ask the question deliberately. Are you really speaking about the broader issues of gender equity, empowerment, or perhaps disempowerment in this case, and human development goals? And why do so many women in Africa still die from cancers that we already know how to detect and treat early? How can we finally break this cycle?
Well, it is a gender inequity issue, and I'm glad you asked that question as we're in the 16 days of activism. And one thing that you will find amongst my quotes is that cervical cancer is the greatest exemplar of inequity that exists in women, because it is a condition where the tools exist to prevent. However, women, whether in high, low income, more so in low income countries, do not have the financial ability and resources to access the care that they need. Before we even come to financial resources, and this is going back to my own experience in northern Nigeria, they don't have the decision-making power to go to the hospital to treat malaria or to have antenatals. The majority of the women living in those communities are not able to leave their homes without the consent of their spouses. So then the finance comes in.
Sure.
And the issue of how much do they know, how much do they understand from what they're being taught in the hospitals, or what treatment they're being given. And then how are they treated in the hospitals? Who treats them? Abroad, women prefer to be seen by a woman.
Absolutely.
So many studies have shown that they prefer the care, their antenatal care, from a female gynecologist. But we do not have enough. We don't have the nurses. We don't have, and then you come to the other end, the radiologists to treat the cancers. They're few and getting fewer. So I think that inequity is stark.
Yes.
The way that we empower our women with the knowledge, with the resources, with the capacity to be able to access care from diagnosis to treatment has to change. And you're right, the commonest cancer in Nigeria today is breast cancer and cervical cancer. So those two, prostate cancer is in between, but those two carry the bulk of our recorded figures of, I think it's about 130. I flip it aside because I know it's much more. We're not recording what should be, how we should be for a population of our size. We have equitable countries, populations like Brazil, that their data shows they record about 400,000 new cases of cancer every year. We are reporting 120, and where are the rest?
Absolutely. I mean, Dr. Zainab, I think we can agree, in my view, of course, what you've demonstrated so far in this conversation is a deep and fundamental understanding, not just of the problem, but the genesis of it, and the multifaceted, multidimensional nature of the problem that confronts our society. And no wonder you are quite often described as the first lady of cancer prevention in Africa.
I like that title.
Yeah, you do. Yeah, me too. But quite frankly, in reality, you were, of course, the first lady of Kebbi State, Nigeria, from 2015 to 2023. I'd like to ask, incredible opportunity, of course, and you sound as though, of course, you have a sense of occasion, you understand the responsibility that a platform and an opportunity like that brings. What precisely did that platform do for you? How has it helped you in what you're doing now? And what were you able to achieve on behalf of your local communities in Kebbi State? I'm assuming, of course, that you championed wide-ranging health initiatives beyond cancer.
Yes, we did. I tried to. It's a difficult question. It's a platform that anyone can achieve with. And I tried to focus more on health, women. And then, of course, when I say women, not just their health, education, empowerment, and the youth and children. I was biased towards the children a lot because, there were issues with nutrition, with delivering. The first visit I got from, as First Lady, was from the Nigerian College of Pediatricians, the Pediatric Association of Nigeria. And they brought the numbers for me to show me how poorly we were doing with routine immunization. And we worked on that a lot. It's grounded me, the whole experience grounded me. Our problems are really multifaceted. It's about government. It's about the people that make up governments at different levels, about the funding, how it's allocated, how it's utilized. You could get funding for immunization to procure syringes, and somebody in the ministry will tell you that, they used it to travel to a workshop in Lagos, and they will relate it to immunization for both the government and the audits and the partners. But really, I want to see immunization syringes and solar powered refrigeration for the cold chain So it was difficult. And I started, and then you can't fight the system. There's a whole system that exists, and no matter how much you try, and don't forget that this position is an unconstitutional one.
Yes.
You wield some power, but it's soft power.
Yes.
And there's really nothing much you can do. And a very clear pointer towards that statement is the fact that the minute we left Kebbi, a lot of our programs started being dismantled. And so today, some of the plans that we had put in place are not there. The progress that we made in immunization is reversing. It's not because the governor is any worse than my husband was or he's better, but it's because the champion, i.e. me, that was there is missing.
Of course.
So other first ladies coming with their own projects, and that's why you have to really try as a first lady to institutionalize your programs. So I think one of the greatest things that we were able to do was to raise that immunization cover in Kebbi State. We brought it from under 20 to over 18 at some point. COVID dipped it a bit, but today I think we're at about 50. And we were able to do that. Yes, coverage. And we were able to do that with the support of the Kebbi State government, the governor's leadership, and partner. I would advocate for Kebbi's inclusion in more national programs and funding from the World Bank, from Gavi Alliance, and it worked. We got a lot of solar fridges that were distributed, and it was it was a system training, the whole strengthening program, and they did a lot of education to the community health extension workers. I love community health extension workers. I think they're the backbone of our health system. And if we treat them right and train them right, remunerate them right, then we will get better results, and all that late detection that we're talking about, the women giving birth at home and losing their lives, losing the babies, the high maternal mortality rates that we have today, will start to change. There are programs that are targeting them now, which is good, and we hope to see more of that. You'll be surprised that a lot of misinformation comes from that level, from the healthcare workers. So by working with them more and really seeing them as parts of the system, not just low end of the whole stick, we will certainly see improvement.
Absolutely. And Dr. Zainab, I trained as a primary care physician, and primary care, of course, can become this catch-all for all sorts of many things that legitimately fit under that umbrella. But I'd like you to delve a bit deeper and talk to me, since we're talking about community health, about the National Cancer Screening Program, or to whatever extent that exists in our country today.
So a national screening program is supposed to be in existence and implemented at the relevant, so that the relevant cancers are picked up early. Men of whatever age, based on the research and demographics of the area, a Black man should present himself for prostate cancer screening at an earlier age than his Caucasian counterpart. So we say 40 or 45. Abroad, you'll find some countries go as high as 60. But from 40, because if you look at even just the average life expectancy in Black, particularly low middle income country men in Africa, it's much lower.
Yes, of course.
We don't live to that high age. So the screening has to come earlier. So basically, there should be a system in place for the common cancers that we can detect, of which there are quite a few. And the system, the plan is there, but there is no system that is implementing it. And that's where the primary health care is important. And strengthening that level of care, providing the human resources that we need to be able to detect it, to carry out that plan. And then the use of technology. We have digital technology now that is really, really racing AI is just racing through the roof in so many aspects of healthcare. But again, we're being left behind.
Yes.
The artificial intelligence models that will be presented to you today for breast cancer detection has just about 1% of African models in it.
Of course. So I'd like to move on now to talk about you and the wonderful things that you're doing globally. Okay. You are, as of now, President-Elect of the Union for International Cancer Control. And that's one of the most influential cancer prevention bodies worldwide. You are, in fact, the first African to hold that position. You previously served as a board member from, I believe, 2020 to 2024. So you've done the night shift, haven't you? So what does this moment represent, in your view, for Africa and for low and middle-income countries in general, in terms of global health governance?
Okay, so I think that my experience in different ways for the past 20 years contributed to that position. And though I was a board member for, I think, 3 terms before being elected, it was the work that I'd been doing prior to that global position in our communities that really spoke. And one of the first things they tell you when you come on the board of the UICC is you're representing cancer control. You're not representing your countries. However, 2 days later, you will get an email asking you to speak about breast cancer in Nigeria.
Of course.
So my colleague from Sweden is not going to get that email. Like I won't get that. So in a way, it works for everybody. I bring my experience to the table, and that is what has helped me to get to where I am. And it's important that for the first time we have a representation clearly from Africa with the ability and the understanding and experience of what it's all about and how we can do it. So it's not textbook. I speak from experience, I act from experience, and I intervene in the organization's plans from experience of a low middle income country. And more, again, very importantly, I try to bridge those two ends. I have worked in a high-end country, high-income country. I have seen the systems there, all this primary health, calling up digital technology. You get a letter, you get a text message, you get an email, everything calling you to come for your breast screening. Once you hit a certain age, the system knows you exist. Are we registering all our people? Do we know that they exist? So that kind of strong system, it comes to play from different aspects. It's not the doctors that are registering. It's another department in government. The doctors give birth, and yes, the hospital registers the birth, but someone else is responsible for the data of the country and planning and getting to where they want to be. So I can see that in my dreams. I've seen it, I've lived it, and I want my country and countries like mine to catch up. So if I see an organization like Gavi wanting to provide extra vaccines or for some other disease, I can cut in and say, no, let's allocate more to rotavirus, which is killing children, diarrhea all over the place, as opposed to that. And I think it's worked well and it's working.
Dr. Zainab Shinkafi-Bagudu, thank you for joining us.
Thank you for having me. Thank you for having me. It's a pleasure.
Real pleasure.